The first TAVR tsunami came soon after the initiation of this transformative technology. The second tsunami will be a huge wave formed by a demographic surge in the elderly population that will have a high prevalence of degenerative aortic stenosis. This should be interesting. The magnitude of the wave and the multifaceted implications really need to be understood, so for that, we are turning to the October 11th issue of JACC and a paper on late outcomes of TAVR, and this is in high-risk patients. It is the FRANCE-2 Registry, and to talk about this, I'm with Professor Martine Gilard, who is an MD, a PhD from Brest, France, who on the west side of France, I understand.
Yeah.
Now, in this particular paper, we're talking about an issue that's only going to be getting worse, but you've got the largest database available on late results of TAVR. Just how large is it, and how impressive is it?
It is impressive because we have it was all the TAVI implanted in France consecutively, all TAVI, no exclusion criteria. And we follow them during 5 years, so we publish a 3 years late outcome. And this we have the answer of every patient in 97% of cases. So it's a very, very good follow-up, and I think it would be a good data for that.
So what have you learned from this most recent analysis?
We learned that there is an increase of death. It's normal because patient was a very high-risk patient, and the mortality is 42% of the initial cohort. However, there is only 17% of patients who die from cardiovascular death. So it is after the past 3 or 4 months, it is only the comorbidity we increase the death, but not the cardiovascular cause. So I think it's a very important thing. When people have a TAVI, they have some problem at the beginning, but after, the mortality, the rate mortality of these patients are lower than the same patient in the normal population. So it's a good thing. It's a good treatment.
What are the big lessons that you think this data supplies us that we didn't know before?
We show, because there is a very large one. It was 4,000 people who are included in this registry, and we have the opportunity to have the echo in 97% of cases. And we have echo in 3 years, we have also echo in 4 years, but all the patient has not 4 years follow-up, but we have 80% of echo. And you know there is a problem about the degenerations of TAVI, but in this trial, nothing at all. And it's a large one, and the echo is good months after months. So we don't see any deterioration as some people mention.
That's very encouraging. Yeah, that's been in the news, and it's been it's definitely got a lot of attention.
Yeah.
And so you're saying, at least with what you're seeing with these large numbers, there's nothing to be concerned about in this study. Accompanying your paper, there's an editorial comment. It's called TAVR Prognosis, Aging in the Second TAVR Tsunami. They're the ones who gave me the opening there. And it's insights from France. It's John D. Carroll. He talks about the tsunami in terms of, to give US numbers, the elderly population will reach 50 million by 2019. That's not very far away. And 1 in 5 US citizens will be elderly, coming up by 2030, with 8.5 million reaching the oldest of the old. This is an important topic, and this is a technology that's going to be applied to a lot of people.
Yeah, I completely agree, because it's a good treatment for all patients. I think it will be a good treatment for intermediate risk, and for example, actually in our center in France, we increase the number of TAVI, and for example, in 2030. We have only 3,000 TAVI in France, but actually we have more than 8,000 TAVI performed in France. So I think this is a terrific treatment for these old patients, but it's also a good treatment for intermediate patients. So I think it's a good way to treat our patients better, I'm so sorry, than surgery.
Well, TAVR versus SAVR, and TAVR certainly seems to be winning here recently. Did you analyze the data at all, male versus female?
Yes, we do that, and the one predictor of mortality was the gender. If you are a man, You have more risk of die than a woman. So women who have a bad experience with surgical valve replacement, because for women they increase the mortality compared to men. In TAVI it's exactly the opposite. If you have a female, you take advantage to be treated by TAVI than by surgery.
What's interesting is they sometimes, at least according to one study we've talked about here, the perioperative risk for women is a little higher. But over time, they do much better.
Yes, exactly. And we don't know exactly why, but...
that was my next question.
Because we are a female, we are exceptional. But,
this is true.
So I think for female, we have a afraid female and so on. It's better to have a TAVI than a surgery.
So what questions are you going to ask in the next study or the one after that? What do you still don't know that you want to?
First of all, I would like to know if we can apply to everybody. So as Partner 3 give us perhaps the solution, the data about that. So this is important to extend this treatment to patients who have not so high risk, first. And the second is the degenerations. We have to know, because some guy said TAVI there is a degenerescence of the bioproteases of TAVI more than the surgery. I am not so sure. So I think we need to know that. And actually, there is in France a lot of patients who have 7 years old, 7 years between the implantation and actually. And we need to explore them. We need to make echo and to publish it in order to reassure everybody it's a good technique.
Well, Professor Martine Gilard's paper is in the October 11th issue of JACC 2016. It is the France-2 Registry. You can learn a lot more by looking at that paper. We are in Rome and at the ESC meeting for Cardiol Source World News and Cardiol Source World News Interventions. I'm Executive Editor Rick McGuire.